Thanks. Thank you. Okay, we are moving into the second hour of this presentation, and I'd like to encourage everyone to just raise their hands above their heads, get some blood flowing for a second. Okay, stand if you need to, but don't leave, okay? Because we have some very exciting presentations coming. So the next presenter is Dr. Camille Moreno, who is an assistant professor in the Department of Obstetrics and Gynecology at the University of Utah. She also serves as a medical director for the Midlife Women's Health and Menopausal Medicine Program. She is a board-certified family medicine physician and fellowship-trained midwife women's health specialist. Oh, not midwife, midlife. L, not M, they're close to each other. She's a North American Menopause Society, or NAMS, certified provider, which is actually special, I just found out this morning. And her special interests include menopause, perimenopause, menopausal hormone therapy, non-hormonal treatment options for vasomotor symptoms of menopause, bone health, cardiometabolic health changes in midlife, sexual health, and female sexual dysfunction. Oh, wait, and vulvar disorders. So we'll hear from her, and then we're going to hear a blitz from our poster highlights.
Thank you so much, and welcome everyone. Welcome to Economics 101. Just to give you a brief background, I do not have a econ or finance background. I don't have MBA after my name, but I, just like Susanna, I am inspired and motivated to do the work that I do from the patients I meet and the stories I hear. And so menopause is having its moment in the news and in the media currently. So this is a topic that has been widely publicized, and we actually had there was an article published in the New York Times not too long ago on the economic burden of menopausal symptoms. And so here this afternoon, I would like to talk about the real cost of symptomatic menopause. But before we dive deeper into the presentation, I would like to provide a few updates about our Midlife Women's Health and Menopause Medicine program that was launched about 2 years ago, and with the support of the Department of OBGYN, Dr. Bob Silver, Erica Lindley, and also the fearless leadership of Dr. Curtly Parker-Jones, who's here with us, Leanne Johnston, as well as Tree Swanson, and also the support of the Center of Excellence in Women's Health, who's hosting such a great symposium today. I would like to thank them because since then, over the last 2 years, we have 8 North American menopause certified providers here at the University of Utah, serving midlife women in our communities and our surrounding states. And we would like to invite healthcare professionals from all backgrounds, not just physicians, nurses, nurse midwives, nurse practitioners, but also pharmacists, social workers, to become menopause certified if this is truly a special interest of theirs. Dr. Curtly Parker-Jones actually created a series of educational modules, teaching videos that you can watch and have access to before you sit for your North American Menopause Certification exam. And also, I would like to talk about this co-project that I have with the amazing Dr. Lisa Taylor Swanson, who couldn't be with us today. But this is new and unique in its kind, not just at the University of Utah, but really across the country. This is an integrative medical group visit targeted for perimenopausal and menopausal women, which we are coining MenoGap. And this is filling a gap in menopausal care. So hoping that with all the logistics planning and all the planning we've had in the last few months, we can provide and launch MenoGap, where each session provides a menopause, perimenopause 101, so education on symptoms, stages of life, midlife specifically, treatments, timing, duration of symptoms. So anything you want to know about menopause, perimenopause will be available to participants in MenoGap. And also this is billed similar to a medical visit. And so Health screenings are provided, referrals for any health maintenance, such as mammograms, bone densities, colonoscopies, lab testing. But what's unique and special about this, which is similar to what OB does in centering, is that we provide group acupuncture as well as integrative health self-care measures, such as mindfulness, meditation, acupressure, as well as recipes for well-balanced meals. And so just wanted to plug MenoGap. So here is an outline of our learning objectives. First, reviewing the menopausal epidemiology and demographics here in the US, as well as explaining not just the symptomatic burden of untreated vasomotor symptoms, but also the economic burden and how this is impactful on loss of productivity at work. And then lastly, although again, I don't have an econ background, but we're gonna review very superficially pharmacoeconomic studies and cost-effective studies of the management of these menopausal associated vasomotor symptoms, specifically as it relates to hormone therapy. Here are my disclosures, which do not relate to this presentation. And so to go over first the demographics of midlife women here in the US, we know that about 95% of women will have their final menstrual period between the ages of 45 to 55. And we know that the average age of natural menopause is between 51 and 52. Women are living longer. They make up about 20% of the population, specifically midlife women over the age of 50 here living in the US. Over 60% survive at least until 80 years of age, and women spend about 40% of their lives in their menopausal and postmenopausal years. And up to 85% of women are navigating the menopausal transition, which we also know as perimenopause, which overall impact their health and quality of life, and also work, which we will talk about here. And it is actually estimated that by year 2025, the number of postmenopausal women globally is expected to rise 1.1 billion. So this truly represents a public health crisis with a demand for us, clinicians, to become knowledgeable in the provision of comprehensive midlife women's healthcare. And we also know that the symptom burden is real, right? So symptoms are lasting longer than previously believed. And there are certain factors that predict shorter or longer duration of hot flashes. And we know hot flashes last for a median average of about 7 to 10 years. And so women who are experiencing their symptoms in their premenopausal or perimenopausal years tend to suffer the shortest. And also women of Asian descent, such as Japanese and Chinese women, also have shorter hot flash duration. Women who have higher educational attainment, so beyond college years, and those who are never or almost never stressed. We can't really find those women. And those who do not have comorbid anxiety or depression also suffer the least and the shortest. What about those who suffer the longest and also suffer from severe hot flashes and night sweats? So symptoms that start in your perimenopausal or premenopausal years. So I guess I mentioned earlier, shorter would be at menopause, not peri. So I misspoke. And then women also of color, those from African American and Hispanic descent also suffer the longest and actually suffer through the menopausal transition also the longest, not just beyond that. Women who have less educational attainment, who are stressed at least sometimes, and who have depression and anxiety also suffer the longest. Other factors predictive of longer hot flash duration you see here. So women who are financially strained, who are single, no social support, body mass index or highly weighted individuals, and also smokers tend to suffer from these hot flashes earlier on. But menopause is not just hot flashes, and it's not just your period stopping. It begins earlier than you might think. And in fact, in about 20% of women, menopause and perimenopausal symptoms can happen anywhere starting in the late 30s, early 40s. So keep that in mind. So there are physical, somatic, and cognitive deficits that lead to psychosocial impairment. And we know that vasomotor symptoms is a big symptom, constellation of symptom, but overall significantly have a negative impact on a woman's quality of life. Women who become flushed and sweat profusely, especially in a social setting or a work-related environment, may cause them extreme anxiety, and this can lead to social isolation. And feelings of psychological distress may actually arise from sleep deprivation, mood swings, mood disturbances, and also unpredictable hot flashes and night sweats. And before menopause, most women had a monthly hormonal rhythm, right? They had hormonal cycles that were predictable. And then when they enter perimenopause or the menopausal transition, these cycles become disrupted due to the erratic hormonal fluctuations. And this overall disturbs a woman's sense of well-being. And these changes also tend to occur during the lives of women when they're also experiencing significant life changes, including becoming divorced, becoming widowed, children leaving the home, for example, and also taking care of their elderly parents. So being in this sandwich generation. In addition, body dysmorphic disorder, so concerns about how they look, how they feel, also become a major concern. So Dr. Wolf-Udian, who considered menopause as a potential health-related issue back in the 1960s, developed this algorithmic approach of factors affecting costs of menopause-related vasomotor symptoms. So as you see here, those menopause-related vasomotor symptoms included sleep disturbances, mood swings, cognitive slowing, and deficits, which we mentioned earlier, that overall reduce quality of life for women, including work-related disability, social isolation, and embarrassment. And this increases economic health burden, increase in healthcare utilization. By how? How is it increasing healthcare utilization? Increase in physician visits, increase in the use of over-the-counter medications, prescription therapies, lab fees, follow-up testing, as well as phone calls, and nowadays MyChart after the initial consult, and also visits to many medical specialists, as well as alternative medicine practitioners and providers. Also, we see this increased economic burden of untreated vasomotor symptoms that affect the loss of productivity of women, both at home and at work. And in fact, they also looked at increased energy usage from use of air conditioning, using your washing machine, cleaning your clothes, and also costly hygiene-related personal care products. And so we know that overall, hot flashes are not just bothersome, they reduce a woman's quality of life, but they also increase healthcare burden and utilization. And in fact, the annual costs of vasomotor symptoms has been reported to be between $248 to $770 per woman. And this also is costly from the sick leave perspective, or days away from work. And we also can see this with decreased hourly productivity in midlife women by 12.2%, and also decreased annual productivity by 10.9%. So this is more costly than osteoporosis management for lipid disorders, acid reflux, or GERD. So why does this need to be addressed? Because women face productivity challenges when they are at or near the peak or apogees of their career. And up to 1/3 of women's symptoms go unaddressed. And also, women feel like they do not have any support, no one to turn to, no one to ask. A family member may have gone through it, but did just fine. Going to their healthcare provider also increases the cost for them, and it may take 5 to 7 providers for them to get help. So there's also a lot of health issues that arise, not just in menopause, but in perimenopause, including heavy, irregular bleeding, weight gain, headaches, irritability, mood disorders, and all of those things have a major impact on women's work and health and safety issues. So this also contributes to the chronic pay gap, or what we call the mommy tax, which further exacerbate gender inequities and gender equity trajectories. So again, big picture, but how many women seek treatment for their symptoms? And this was a population-based survey of women between the ages of 40 to 65. And 60% of them did seek care for their symptoms. Specifically, hot flashes is the number one concern. 34% of them use hormone therapy to help their symptoms, 12% use complementary alternative medicine therapy, and 16% use both. And this leaves about 38% of women still untreated, unfortunately. So what is the UK doing? Since they are paving the way when it comes to addressing this economic health burden and work productivity loss. So the UK's Chartered Institute of Personal and Development reported back in 2019 that about 59% of women between the ages of 45 to 55 experiencing menopausal symptoms said that their work was impacted. 900,000 women between this age group actually left their jobs. Another survey of about 500 women that was recently published in 2021 said that about 42% had considered leaving their jobs because of perimenopausal symptoms. And the biggest issue was sick pay. Women were reluctant to give their reason for their absence or their sick leave because of the fear of being harassed, ridiculed, or face age discrimination. What about in our own environments? What about in the US? So this was actually an older study of 60 self-insured Fortune 500 companies in the US between 1999 and 2011. So over 252,000 plus women were studied, and these were women who had untreated vasomotor symptoms, so hot flashes and night sweats, had overall higher healthcare resource utilization than women in the control group who were symptom-free. And that we know. We were able to see Udian's work that stemmed from the 1960s. But we also know that over 82% of these women had higher all-cause outpatient visits, and even 121% higher vasomotor-related outpatient visits. So that equaled to an average of about $1,336 per midlife woman. In addition, if that wasn't enough, with vasomotor symptoms, these women also had about 57% more work productivity loss, more productivity loss days than those who were not bothered by their symptoms. And so this truly led to an indirect economic loss due to missed work, which was an extra $770 per woman per year. And that was Dr. Phil Sorrell's work out of Yale. So in addition to economic health burden, but also burden on productivity, which they defined as work productivity loss is disability plus medically related absenteeism. These women who were experiencing moderate to severe symptoms also led to costly outcomes. So untreated vasomotor symptoms, according to Dr. Whitley Wagner's study, cost about $800 million per year. And this is truly a problem we cannot afford to ignore. So this was the recent publication in the New York Times showing the staggering cost of menopause for women in the work. So this article stated that menopause costs Americans an estimated $1.8 billion in lost working time per year, according to a Mayo Clinic study. And this Mayo Clinic study surveyed over 4,000 participants at 4 of their different clinic sites. And about 15% had either missed work or cut back on hours because of their menopausal symptoms, which they defined as adverse work outcomes. And those who reported the very worst symptoms were 16 times more likely to report such adverse outcomes. And the higher percentage were seen in women of color, such as Black and Hispanic women, who reported more adverse outcomes compared to white women, which we know correlates with the study of women's health across the nation, or SWAN study data. And then what about other secondary health conditions that can be attributed to menopausal with these disorders or diseases that you see here on the screen? Hypertension is costly as well, and midlife women are at risk for hypertension as soon as they enter menopause, and that costs the US about $12.9 billion a year. What about osteoporosis? We know that 1 in 2 women will sustain an osteoporotic-related fracture, and that is also costly at $2.7 billion per year. And comorbid depression and mental health disorders will cost the US $8.7 billion per year. So is there hope, right? So the cost effectiveness studies for menopausal symptoms, and I looked at specifically hormone therapies. Menopausal hormone therapy has been shown to be cost effective for the relief of menopausal symptoms ranging from mild to severe. Although it is not cost effective for those who are not bothered by their symptoms, and it also is not cost effective for prevention of medical diseases associated with postmenopause. So the cost effectiveness of menopausal hormone therapy ratio is reported between 10,000 and 1 million per quality adjusted life expectancy. And several factors that contributed to improved cost effectiveness included longer duration of therapy, presence of menopausal symptoms, and minimum side effects and adverse events from hormone therapy. But also non-hormonal therapy options such as SSRIs and SNRIs were also deemed to be relatively cost-effective, similar to menopausal hormone therapy. So how can we create a menopause-friendly workplace? How can we cultivate a supportive culture for menopausal women? One is simple, encouraging workplace conversations about it. So I actually was invited to speak at the Zions Bank Midlife Women's Monthly Business Forum back in January. And it was a talk on perimenopause and how women can better prepare for this. So these conversations are happening, and maybe having a specific peer-to-peer support group in workplaces also may make this can have conversations and promote conversations around menopausal symptoms. Implementing workplace adjustments, such as promoting flexible work hours, hybrid environment, for example, to accommodate not just the medical impact, but also the social isolation that these menopausal symptoms bring. An employer should also have a menopause policy in place, which I will let you know briefly about what the UK is doing. And also negotiating rights for menopausal women. Sickness or absence policies should not penalize women who have to take time off work because of their symptoms and ill health. So including paid time off from medical appointments, and also allowing women to have regular screenings related to menopause, as well as menopause-related health conditions. So I like what I mentioned earlier, the UK is paving the way. UK officials have worked with the British Menopause Society to address menopause in the workplace by creating specific guidelines as well as what to consider. And overall, the guidelines have consisted of 4 major components, including education, raising awareness, increasing conversation about it, legalizing issues around menopause, as well as having the responsibility for or duty of care of employers on their employees' health and well-being. And if you would like more access and resource to what the UK is doing and how to improve menopause in their workplace, I have 2 slides dedicated to that. And if you want to hear and learn more about the Midlife Women's Health and Menopause Medicine program here at the University of Utah, we also have a QR code, which is special. And that's my email for any further questions.